Welcome back to the Deep Dive. We're here to really unpack complex topics, looking closely at the source material to give you the essential insights you need.
That's the goal.
And today, we're diving into a really critical area, the cardiovascular system, specifically how we assess it. Our guide is a foundational chapter on assessment, and we're aiming to give you a clear roadmap for understanding perfusion, fluid balance, and importantly, heart failure.
Exactly. When we talk about assessing the heart, the big concept is perfusion, getting that oxygenated blood out to the tissues.
Right.
And tied right into that is fluid and electrolyte balance. Because if the pump itself, the heart, or the plumbing, the vessels, or even just the amount of fluid is off, well, oxygen delivery suffers. Tissues can get injured fast.
So this deep dive is really about understanding the signals, the metrics, the signs that tell us trouble is brewing, especially when it leads to conditions like heart failure.
Precisely. It's about recognizing the patterns.
Okay, so let's start with the absolute basics, the core mechanics. If we want to know if the system's working, we need the language. What are the key metrics?
Well, the central number we think about is cardiac output, or CO. You can think of CO as the total amount of blood the left ventricle manages to push out into the body over 1 minute.
Okay.
For a healthy adult just resting, that needs to be humming along between, say, 3 to 6 liters per minute. If it drops much below that, well, the body's essentially starved for oxygen.
And CO itself isn't something you measure directly, is it? It's a result of two other things working together.
That's right. It's a calculation. It comes down to heart rate, HR, simply how many times the ventricle beats per minute multiplied by the stroke volume, SV.
Stroke volume being the amount pushed out with each single beat.
Exactly. So CO equals HR times SV. If the heart beats too slowly, or if each beat doesn't push enough blood out, your cardiac output tanks. Those two factors, rate and volume per beat, are where everything starts.
So we've got the volume going out. But we also need enough pressure behind it to actually reach the important organs, right? That brings us to mean arterial pressure, or MAP.
Right. MAP is crucial. It's the average pressure in your arteries across the whole heartbeat cycle, the contraction and relaxation phase, and it's the pressure needed to keep blood flowing to the really vital organs.
Like the brain and kidneys.
Absolutely. Those are non-negotiable. Clinically, you're often trying to keep that MAP somewhere between 60 and 70 millimeters of mercury. If it dips below 60 for too long, you risk cutting off blood supply, causing ischemia, maybe even permanent damage.
Okay, this is where it gets really interesting for understanding heart failure. The forces acting on the heart, preload and afterload. Let's tackle the resistance first, afterload.
Okay, afterload. Think of it as the hurdle the ventricles have to jump over to get blood out. It's the pressure or resistance they face when they try to eject blood.
Like trying to push open a really heavy door?
Exactly like that. And what makes that door heavy? Mostly two things. The patient's overall arterial blood pressure. If the pressure in the aorta is already high, the ventricle has to push harder, and how constricted or dilated the peripheral blood vessels are. Narrower vessels mean higher resistance.
So if someone has high blood pressure, maybe their vessels are clamped down, their afterload is high, the heart muscle is working overtime just to pump blood out.
Precisely. And the consequence?
Yeah.
Increased workload, which means the heart muscle needs more oxygen itself. If this goes on chronically, you risk ischemia, and the heart muscle might thicken up hypertrophy trying to compensate, but eventually that thickened muscle can become stiff and less efficient. High afterload is just chronic strain.
Okay, so that's the resistance after the squeeze. What about what's up the squeeze? That's preload.
Right. Preload is all about the stretch. Specifically, it's the degree the myocardial fibers are stretched right at the very end of diastole, that's the filling phase, just before the ventricle contracts.
And what determines that stretch?
It's all about volume. How much blood has returned to the heart to fill the ventricle? You've got venous return coming back to the right side from the body, and blood coming back from the lungs filling the left side. We often talk about the left ventricular and diastolic volume, or LVED volume. That volume dictates the stretch.
The source mentions Starling's law here. How does that fit in, especially with heart failure?
Starling's law is fundamental. It basically says that up to a certain point, the more you stretch those muscle fibers, the stronger the resulting contraction will be. Think of stretching a rubber band. A good stretch gives you good snapback.
Right. Optimal stretch equals optimal contraction.
That ideal stretch gives you the best possible stroke volume.
Yeah.
But, and this is absolutely key for heart failure, there's a limit.
Ah, the catch.
Yes. If you overfill the ventricle, if that LVED volume is excessive, maybe because of fluid overload, the fibers get stretched too much, beyond their optimal point.
Like overstretching the rubber band until it gets weak.
Exactly. The ventricle becomes boggy, kind of floppy, and the contraction force actually decreases. So too much preload, too much fluid paradoxically leads to lower cardiac output. The heart just can't handle the excessive volume effectively. This is central to understanding volume overload in heart failure.
So managing fluid is literally about keeping the right amount of tension on the heart muscle. Fascinating. And overseeing all these rapid adjustments, that's the autonomic nervous system, right? The ANS.
Absolutely. The ANS is the conductor. When you need more output, like during exercise, the sympathetic system kicks in. It releases epinephrine, norepinephrine.
Adrenaline rush.
Pretty much. And that increases both the heart rate and how forcefully the heart contracts. Faster and harder beats.
And when it's time to slow down.
Then the parasympathetic system, mainly via the vagus nerve, takes over. It slows the heart rate down. It's this constant push and pull sympathetic accelerator, parasympathetic brake that keeps cardiac output matched to what the body needs moment to moment.
Okay, that sets the mechanical stage perfectly. But when these mechanics start to fail, maybe afterload stays too high or preload gets excessive due to fluid buildup, that's when the patient starts to feel it. This leads us straight into heart failure symptoms. Let's talk about this subjective assessment, what patients report.
Yes, the subjective side is often where we first pick things up. We start seeing how the heart's struggle impacts oxygen supply, especially breathing.
And often the first sign is trouble breathing, particularly with activity. Dyspnea on exertion, or DOE.
DOE is classic early heart failure, often left-sided. It's shortness of breath that comes on specifically with physical activity. Why? Because when you exert yourself, your body needs more oxygen, but the failing heart can't ramp up its cardiac output enough to deliver it.
So activities that used to be easy, like climbing stairs, suddenly leave them gasping.
Right. It's a sign their cardiac reserve is limited. They might start unconsciously rationing their energy.
Then, as things worsen, the breathing problems become related to position, like orthopnea.
Orthopnea is difficulty breathing specifically when lying flat. The textbook symptom is the patient needing multiple pillows to sleep, or maybe even resorting to sleeping in a chair.
Why does lying flat make it worse?
Gravity. When you lie down, fluid that might have pooled in your legs flows back towards the heart more easily. This increases venous return, boosts the preload.
Which overfills that already struggling ventricle.
Exactly. Particularly the left ventricle and left-sided heart failure. That increased volume backs up pressure into the lungs, causing congestion, making it hard to breathe. Sitting up helps gravity pull some fluid back down, reducing preload, and often gives pretty quick relief.
But then there's the really scary one. Paroxysmal nocturnal dyspnea, PND. Waking up suddenly at night feeling like you're suffocating.
PND is terrifying for patients. They wake up abruptly, often hours after falling asleep, gasping, panicked. The mechanism is related to orthopnea, but delayed and more severe.
How so?
Over several hours of lying flat, that fluid shift from the legs and tissues back into the circulation becomes more significant. It slowly builds up the volume returning to the heart.
So it creeps up on the heart.
Right. And eventually that increased volume overwhelms the failing left ventricle. It just can't pump it forward effectively. Pressure skyrockets back into the pulmonary circulation, causing acute pulmonary congestion, even flash pulmonary edema.
Leading to that sudden, severe shortness of breath.
Yes. They often have to sit bolt upright, maybe dangle their legs over the side of the bed, and it can take, 20 minutes or more for the feeling of suffocation to ease. That duration helps distinguish it from simple orthopnea. This is a hallmark of worsening left-sided heart failure.
Beyond these dramatic breathing issues, there's often just a pervasive sense of fatigue. The source notes it's often worse later in the day.
Fatigue is very common, though nonspecific. But in heart failure, it's often directly tied to that low cardiac output. If the stroke volume is down, not enough oxygenated blood is reaching the muscles.
So the muscles switch to less efficient energy production.
Exactly. They rely more on anaerobic metabolism, which produces lactic acid, and leads to that feeling of profound tiredness, weakness, just feeling run down. It gets worse as the day goes on because their limited cardiac reserve gets used up.
We also need to ask about palpitations, that feeling of the heart racing or skipping beats.
Palpitations are that unpleasant awareness of your own heartbeat fluttering, pounding, racing. It can be from cardiac dysrhythmias, maybe like atrial fibrillation or tachycardia, which are common in heart failure.
But not always cardiac, right?
Correct. It's crucial to rule out other causes too. Anxiety, stress, too much caffeine, nicotine, even things like hyperthyroidism can cause palpitations. So you need a thorough history.
Then there's the more alarming sign of poor forward flow to the brain. Syncope or near syncope, fainting or feeling like you're about to faint.
Syncope means the brain's perfusion got critically low, even if just for a moment. Usually it's due to a sharp drop in cardiac output or a serious arrhythmia interrupting blood flow.
Like the pump suddenly faltering.
Exactly. In older adults, the source points out it might also be related to orthostatic hypotension blood pressure dropping when they stand up, or sometimes an oversensitive carotid sinus reflex, where pressure on the neck triggers a sudden drop in heart rate and pressure.
Okay, before we move to the objective signs, let's hammer home one crucial indicator the patient can track: weight gain.
Absolutely critical. Sudden weight gain is often the earliest and most reliable indicator of fluid retention and heart failure. It signals that the body is holding on to excess fluid before you might even see swelling.
And the source gives a specific metric for this.
Yes, and it's worth remembering. A gain of just 2.2 pounds, which is 1 kilogram, can mean the patient is holding on to about 1 liter of extra fluid in their tissues.
Wow, just 2.2 pounds is a whole liter.
It adds up fast. And here's the kicker. Visible edema, like swollen ankles or legs you can press indentations into, pitting edema, often doesn't show up until they've already gained 10 to 15 pounds.
That's 4 to 7 liters of extra fluid.
Exactly. So relying only on visible swelling means you're way behind the curve. That's why teaching patients with heart failure to weigh themselves daily, same time, same scale, same clothes, is paramount. It's the early warning system for worsening fluid balance, particularly in right-sided or advanced heart failure.
That brings us perfectly to the objective assessment, what we find on exam that confirms these subjective reports and tells us where the problem is, left side versus right side.
Right. The physical exam helps piece it together. We start looking for signs of backup, particularly in the venous system for right-sided heart failure. The key sign there is jugular venous distension, JVD.
Seeing those neck veins bulge out, what does that tell us?
JVD is basically a visual estimate of the pressure inside the right atrium, the jugular venous pressure, or JVP. When the right ventricle isn't pumping effectively, blood backs up into the right atrium and then back further into the large veins, returning blood from the head and neck, like the jugulars.
So bulging jugulars equals high pressure on the right side of the heart.
Precisely. It's a direct sign of increased filling volume and pressure, typically due to fluid volume overload or right ventricular failure itself. We assess it by having the patient sit at a certain angle, usually 30 to 45 degrees, and looking at how high up the neck the pulsation or distension goes.
And if right-sided failure is severe and prolonged, the backup goes beyond the neck, doesn't it?
Oh, yes. The systemic circulation gets congested. You might see peripheral edema, swelling in the feet, ankles, legs, even the sacrum if they're bedbound. In severe cases, you can get ascites, which is fluid buildup in the abdominal cavity.
Making the belly swell.
Right. You might see hepatomegaly, an enlarged liver, because blood is backing up into it, making it tender. And in the most extreme cases, anasarca, that's generalized, massive edema affecting the entire body. These are all signs the right heart just can't handle the venous return.
Okay, moving to blood pressure. We mentioned orthostatic hypotension as a cause of syncope. How do we formally assess for it?
You need to measure blood pressure and heart rate with the patient in different positions. Lying down, supine, then sitting, then standing. And importantly, you wait a minute or two between each position change to let the body adjust.
And what drop are we looking for?
The definition is a decrease in the systolic pressure, the top number, by more than 20 millimeter Hg, or R, a decrease in the diastolic pressure, bottom number, by more than 10 millimeter Hg when moving from lying to standing. Often, you'll also see the heart rate jump up by 10 to 20%, trying to compensate for the falling pressure.
What usually causes this?
It can be simple dehydration or volume depletion. Also, prolonged bed rest can decondition the reflexes, certain medications can cause it, and underlying cardiovascular disease affecting the blood vessel's ability to constrict properly is also a factor.
There's also that more unusual BP finding, paradoxical blood pressure or pulsus paradoxus.
Yeah, this one's less common but very significant when present. Normally, when you breathe in, your systolic blood pressure might drop just a tiny bit, maybe up to 10 millimeter Hg. Pulsus paradoxus is when that drop during inspiration is exaggerated more than 10 millimeter Hg.
Why would breathing in cause such a big drop?
When you inhale, the pressure inside your chest decreases. This pulls more blood back into the right side of the heart. Normally, the heart accommodates this fine, But if the heart is being squeezed or restricted, maybe by fluid in the pericardial sac, cardiac tamponade, or conditions like severe asthma, COPD, or constrictive pericarditis, the expanding right ventricle physically pushes on the left ventricle.
So the left ventricle can't fill properly.
Exactly. The septum bows into the left ventricle, reducing its filling space, which decreases stroke volume and causes that significant drop in systolic pressure during inspiration. It signals some kind of external constraint or severe obstructive lung issue.
All right, let's put the stethoscope on.
Mm.
Auscultation. Listening for sounds that tell us about valve function and, crucially, how compliant or stiff the ventricles are.
First, you need the normal sounds clear. S1, the lub, is the sound of the mitral and tricuspid valves closing as the ventricles start to contract, systole. S2, the dub, is the aortic and pulmonic valves closing as the ventricles start to relax, diastole. Lub dub, lub dub.
But in heart failure, we often hear extra sounds, the gallops, like the S3 sound.
S3 is often called a ventricular gallop. It's a low-pitched sound heard early in diastole right after S2. Think Kentucky, where the Y is the S3.
And what causes it?
It happens during the rapid filling phase of the ventricle. Blood rushes into a ventricle that's already overloaded or stiff, non-compliant. The vibration of the ventricular wall as that rush of blood hits it creates the sound.
And S3 is particularly significant in adults.
Very much so. While an S3 can sometimes be normal in children or young adults, hearing an S3 in someone over, say, 35 or 40 is generally abnormal. It's a classic sign of volume overload and decreased left ventricular compliance, a hallmark of left-sided heart failure.
Then there's the S4 sound, the atrial gallop.
S4 is heard late in diastole, just before S1. Think Tennessee, where 10 is the S4. This sound is generated when the atrium contracts forcefully to push blood into a stiff, non-compliant ventricle.
So S4 points to stiffness.
Yes, often related to conditions that cause ventricular hypertrophy or stiffness, like long-standing hypertension, aortic stenosis, or ischemic cardiomyopathy. If you hear both S3 and S4, that's called a summation gallop, and it usually indicates pretty severe ventricular dysfunction.
We also listen for murmurs.
Murmurs are caused by turbulent blood flow, usually across heart valves. Maybe a valve is narrowed, stenotic, and blood struggles to get through. Or maybe it's leaky, regurgitant, and blood flows backward.
How are they described?
We classify them based on timing. Do they happen during systole, between S1 and S2, or diastole, between S2 and S1? And also by their loudness or intensity, typically on a scale from grade 1, very faint, to grade 6, extremely loud, maybe even palpable as a vibration, which we call a thrill. Murmurs tell you about valve problems, which can cause or worsen heart failure.
Okay. Finishing the physical exam, we look out to the periphery, skin, and extremities for clues about overall perfusion and oxygenation.
We look for cyanosis, that bluish discoloration. Peripheral cyanosis in the fingers or toes might just be due to cold or poor local circulation, but central cyanosis, seen in the lips, tongue, mucous membranes, is much more serious.
Why is that?
Central cyanosis means the arterial blood itself isn't carrying enough oxygen. There's a problem with oxygenation in the lungs, like severe pulmonary edema and left heart failure, or maybe a congenital heart defect mixing deoxygenated blood into the circulation. It's a sign of significant hypoxemia.
And the source also mentions clubbing of the fingers.
Clipping is a change in the shape of the fingernails and nail beds. The angle between the nail and the finger flattens out, sometimes exceeding 180 degrees, and the fingertips can look bulbous.
What causes that?
It's a sign of chronic, long-term oxygen deprivation. You see it in conditions like advanced chronic lung disease, some congenital heart defects, severe chronic heart failure, particularly right-sided. It takes months or years to develop, so it tells you the low oxygen state has been going on for a long time.
So we've gathered the patient's story, physical clues from head to toe. Now we need the inside scoop, the lab work, the imaging.
Yeah.
The diagnostic assessment?
Exactly. This is where we get objective confirmation and quantify the problems. We start with serum markers looking for heart muscle damage.
And top of that list is troponin, right?
Absolutely. Troponin T and troponin I are proteins specific to heart muscle. When heart cells are injured or die, like in a myocardial infarction, heart attack, troponin leaks out into the bloodstream. Elevated levels are the gold standard for diagnosing myocardial injury.
How quickly do they show up?
They start to rise within a few hours of injury and can stay elevated for days. That's why we do serial testing, checking levels every 3 to 6 hours initially to see if they're rising, peaking, and then falling, which confirms an acute event.
What about inflammation? Highly sensitive C-reactive protein, HSCRP.
HSCRP is a marker of general inflammation in the body. While it goes up with any tissue injury, chronic low-level elevation of HSCRP is now strongly linked to the development and progression of atherosclerosis, that plaque buildup in arteries.
So it's a risk marker for future problems.
Yes. Someone with a persistently high HSCRP, even without symptoms, is considered at higher risk for future cardiovascular events like heart attack or stroke. It tells us there's ongoing inflammation simmering in the blood vessels.
The source also mentions homocysteine. Less common, but still relevant.
It's an amino acid. Elevated levels can be an independent risk factor for cardiovascular disease. It's not usually a first-line test, but it might be checked in certain situations, perhaps if someone has premature vascular disease or an unexplained clotting tendency. Sometimes high levels are related to B vitamin deficiencies.
Okay, moving to chronic risk assessment, the lipid profile. Still absolutely essential.
Non-negotiable for assessing risk for coronary artery disease, CAD. We look at total cholesterol. Ideally want that below 200 mg/dL.
Then the breakdown. LDL, the bad cholesterol.
Right, low-density lipoprotein, LDL. This is the stuff that deposits cholesterol into artery walls, forming plaque. We want this low, generally less than 130 mg/dL, but for people with known heart disease or high risk, the target is often much lower, sometimes under 100 or even under 70.
And the good cholesterol, HDL.
High-density lipoprotein, HDL. This acts like a scavenger, pulling cholesterol out of the arteries and taking it back to the liver. So we want HDL levels to be high, generally over 45 mg/dL for men and over 55 mg/dL for women. Higher HDL is protective.
We also absolutely have to talk about electrolytes in heart failure. They're crucial for both fluid balance and the heart's electrical function.
Critically important, especially potassium. Hypokalemia, low potassium, makes the heart muscle electrically unstable. It dramatically increases the risk for dangerous ventricular arrhythmias like ventricular tachycardia or torsades de pointe. Many diuretics used in heart failure can cause potassium loss, so monitoring is vital.
And too much potassium, hyperkalemia, also bad news.
Very dangerous, too. High potassium slows down electrical conduction in the heart. You can see specific changes on the ECG, like tall, peaked T waves. If it gets too high, it can lead to complete heart block and cardiac arrest. The safe range for potassium is quite narrow.
What about sodium? How does that fit into the heart failure picture?
Serum sodium levels often reflect fluid balance. In heart failure, patients are often overloaded with fluid. If you see a low serum sodium level, hyponatremia, it might not mean they lack sodium overall. It often means they have too much excess water diluting the sodium that's there. It's called dilutional hyponatremia, and it's usually a sign of significant fluid overload and worsening heart failure.
Okay, labs give us chemical clues. What about visualizing the heart itself? Echocardiography seems indispensable.
The echo is probably the most useful non-invasive imaging test for heart failure. It uses ultrasound waves to create moving pictures of the heart.
What can you see with it?
A lot. You can assess the size of the heart chambers, measure how thick the walls are, see how well the walls are moving, estimate the ejection fraction, what percentage of blood the left ventricle pumps out, with each beat a key measure of function, and really importantly, examine the heart valves for stenosis or regurgitation. It gives a great overall picture of structure and function.
But for the most detailed look, especially at the coronary arteries, sometimes you need cardiac catheterization.
Right, cardiac cath is the gold standard, the most definitive test, especially for diagnosing coronary artery disease. Its invasive catheters are threaded through blood vessels into the heart.
What can be done during a cath?
You can directly measure pressures inside the heart chambers and major vessels. You can inject contrast dye into the coronary arteries and take X-ray pictures, angiography, to see exactly where blockages are. You can assess valve function precisely. And often, if blockages are found, interventions like angioplasty or stenting can be done right then and there.
Being invasive, it carries risks. What should we be aware of?
Definitely risks involved. For left heart cath, accessing via an artery, risks include potential complications like heart attack, stroke if plaque breaks off, bleeding or clotting at the arterial access site, damage to the artery, kidney injury from the contrast dye, and serious arrhythmias.
And for a right heart cath?
Right heart cath accessing via a vein has slightly different risks, like thrombophlebitis, vein inflammation clot, pulmonary embolism if a clot travels to the lungs, infection, and sometimes vagal reactions causing low heart rate and blood pressure. Allergic reactions to the contrast dye are also a possibility for either type.
Okay, we've got the full assessment picture now, subjective, objective diagnostics. Let's pivot to how nurses use all this information, connecting findings to interventions, patient teaching, and managing those risks, especially in the context of heart failure.
This is where nursing plays such a central role. A huge part of managing heart failure is helping patients control their modifiable risk factors. We need to provide evidence-based education and support.
Top of list, based on the source. Tobacco cessation.
Absolutely non-negotiable. Smoking is just devastating for the cardiovascular system. Nurses should use the 5 A's approach. Ask about use. Assess readiness to quit. Advise quitting strongly. Assist with resources, meds, counseling, and arrange follow-up.
And the motivation is huge, right? The risk drops significantly after quitting.
Dramatically. Within just a few years, their cardiovascular risk starts approaching that of someone who never smoked. It's one of the most impactful things a patient can do.
Next up, tackling a sedentary lifestyle.
Regular physical activity is so beneficial. It helps control blood pressure, improves lipids, helps with weight management, improves insulin sensitivity, and just makes the cardiovascular system more efficient.
What's the recommendation?
The general guideline is aiming for about 150 minutes of moderate intensity aerobic activity, like brisk walking per week or 75 minutes of vigorous activity. Even small amounts are better than none. We need to help patients find activities they enjoy and can stick with, considering any limitations they might have.
And diet. Huge in heart failure management.
Absolutely critical. The focus is usually on a heart-healthy pattern. Lots of fruits, vegetables, whole grains, lean proteins, healthy fats. But for heart failure specifically, the big one is sodium restriction.
Why is sodium so key?
Because sodium makes the body retain water. More water means more fluid volume, which increases preload, making the already struggling heart work even harder. It directly contributes to congestion and edema.
So teaching label reading, avoiding processed foods.
Yes, teaching patients how to track sodium intake, choose low-sodium options, avoid salty snacks and canned goods, limit restaurant meals. It's intensive education, but vital for managing fluid balance.
We also have to address related conditions like obesity and diabetes.
They often go hand in hand with heart failure. Obesity, BMI over 30, or even overweight BMI 25-29, puts extra strain on the heart and is linked to hypertension and high cholesterol. And diabetes, well, adults with diabetes have a much higher risk of developing heart failure and worse outcomes if they do. Managing blood sugar, blood pressure, and lipids aggressively is crucial in these patients.
Okay, shifting to acute nursing actions. What are the absolute priorities in assessment when you suspect something is going wrong?
If a patient reports chest pain, you need a rapid, thorough assessment. Onset, location, duration, characteristics, aggravating, alleviating factors, radiation, timing, severity, using a 0-10 scale. Remember, PQRST or similar mnemonics. Any chest pain that could be ischemic is a top priority time is muscle.
And recognizing that symptoms aren't always classic, especially in women.
Crucial point. Women are more likely to present with atypical symptoms for cardiac events, maybe just unusual fatigue, shortness of breath, indigestion, anxiety, or back pain, rather than crushing chest pain. You need a high index of suspicion and can't dismiss these vague complaints.
Let's talk specifically about nursing priorities for managing the diagnosed heart failure patient day to day.
Okay. The big picture focuses on monitoring and managing fluid balance. This means strict monitoring of daily weights, the most sensitive indicator of fluid gain. Also, careful intake and output tracking, especially if they're on diuretics or fluid restrictions.
Assessing for edema, too.
Yes, regularly assessing for peripheral edema, noting its location and severity, pitting scale. Also assessing JVD and abdominal girth if a SICE is suspected.
What about respiratory status?
Vital. Listening to breath sounds frequently. Are there crackles, especially in the lung bases? That suggests fluid backing up into the alveoli, pulmonary edema. Asking about orthopnea or PND, have they needed more pillows? Are they waking up short of breath? These are red flags for worsening left-sided failure. Monitoring oxygen saturation is also key.
Heart failure patients are often fatigued. How do nurses help with that?
Promoting energy conservation. This involves things like clustering nursing care activities to allow for uninterrupted rest periods, teaching the patient to pace themselves, take rest breaks during activities, maybe sit down for tasks like grooming, encouraging short naps if needed. Balancing activity with rest is key.
And ongoing patient teaching is huge.
Absolutely. Reinforcing the low-sodium diet. Emphasizing the importance of taking medications exactly as prescribed, understanding what each med does, and potential side effects. Teaching them how to monitor their daily weights and when to call the provider specific parameters like gaining 2-3 pounds in a day or 5 pounds in a week, or increased shortness of breath, swelling, or dizziness. Empowering them to recognize early signs of decompensation is critical to prevent hospital readmissions.
Perfect. Now, let's briefly highlight some key medications used in heart failure, touching on how they work and nursing considerations. Maybe start with digoxin.
Okay, digoxin. It's an older drug, a cardiac glycoside. Its main actions are increasing the force of the heart's contraction positive inotropy, which helps improve cardiac output, and slowing the heart rate, particularly by slowing conduction through the AV node.
Nursing focus for digoxin.
Big one. Check the apical pulse for 1 full minute before giving it. Hold the dose and notify the provider if the heart rate is typically below 60 BPM. Also, monitoring for digoxin toxicity is crucial, as it has a narrow therapeutic range. Symptoms include nausea, vomiting, anorexia, fatigue, visual changes like seeing yellow-green halos around lights, and confusion. Low potassium levels increase the risk of toxicity.
What about diuretics, like furosemide, Lasix?
Furosemide is a potent loop diuretic. It works in the kidneys to block sodium and chloride reabsorption, causing the body to excrete more sodium, water, and also potassium. This rapidly removes excess fluid, decreases preload, and helps relieve symptoms of congestion like edema and shortness of breath.
Key nursing points for furosemide.
Monitor fluid status closely INO, daily weights. Watch potassium levels very carefully as it causes potassium loss, hypokalemia. Potassium supplements are often needed. Monitor blood pressure as removing fluid can cause it to drop. Teach patients to stand up slowly to avoid orthostatic hypotension and dizziness. Also monitor kidney function.
Let's talk about ACE inhibitors, like lisinopril.
ACE inhibitors, angiotensin-converting enzyme inhibitors, are cornerstone drugs in heart failure. They block the conversion of angiotensin to angiotensin II. Angiotensin II is a potent vasoconstrictor and also stimulates aldosterone release, which causes sodium water retention.
So blocking it causes.
Vasodilation, relaxing the blood vessels. This reduces afterload, making it easier for the heart to pump blood out. It also reduces preload by decreasing sodium and water retention. Overall, they lower blood pressure and reduce the workload on the heart, shown to improve survival.
Nursing focus for ACE inhibitors.
Monitor blood pressure carefully, especially with the first dose. Monitor kidney function, BUN, creatinine, and potassium levels, as they can sometimes cause potassium retention, hyperkalemia. A common side effect is a persistent dry cough. Patients need to report this. A rare but serious side effect is angioedema, swelling of the face, lips, tongue.
And beta blockers, like metoprolol, they seem counterintuitive, slowing the heart.
They do slow the heart rate and also decrease the force of contraction slightly, which reduces the heart's workload and oxygen demand. They also block the harmful effects of chronic sympathetic nervous system stimulation on the heart muscle.
So they protect the heart long term.
Exactly. While they might be started at low doses and increase slowly, beta blockers have been proven to improve survival and reduce hospitalizations in patients with systolic heart failure.
Nursing points for beta blockers.
Check heart rate and blood pressure before giving hold if HR is too low, usually 50-60, or BP is too low. Teach patients not to stop taking them abruptly, as this can cause rebound tachycardia or worsening symptoms. Watch for side effects like fatigue, dizziness, bradycardia, and sometimes worsening HF symptoms initially, which usually improve. They can also mask signs of hypoglycemia in diabetics.
That's a great overview of the key med classes. Now, briefly, what are some major complications of heart failure nurses need to be vigilant for?
Top of the list is acute pulmonary edema. This is a medical emergency where fluid rapidly fills the alveoli. Patients become extremely short of breath, anxious, may have pink, frothy sputum, and low oxygen levels. Needs immediate intervention.
What else?
Renal dysfunction or kidney injury is common. It can happen because of poor perfusion to the kidneys from the low cardiac output, or sometimes as a consequence of aggressive diuresis, overdiuresis. Monitoring kidney function labs is vital.
We mentioned digoxin toxicity already.
Yes, always a concern, especially in older adults or those with fluctuating kidney function or low potassium.
And the most severe outcome?
Cardiogenic shock. This is when the heart failure is so severe that the heart simply cannot pump enough blood to maintain perfusion to vital organs, leading to multi-organ failure. It has a very high mortality rate. Early recognition of worsening failure is key to preventing these severe complications.
Okay, let's wrap this up. We've covered a tremendous amount, from the basic mechanics like preload and afterload, through the subjective and objective signs of failure, JVD, P&D, S3 sounds, weight gain linking them to left and right-sided failure, diagnostics, key meds, and crucial nursing priorities.
It really highlights that heart failure is complex, but understanding these assessment pieces is fundamental to managing it. It's about recognizing patterns, monitoring closely, and intervening early. Recognizing those early signs, like the weight gain or needing an extra pillow, can make a huge difference in keeping patients stable and out of the hospital.
Absolutely. It's a progressive condition. But with good management medications, lifestyle changes, and crucially, patient education and support, people can live well with it.
And that management really requires a team effort, nurses working closely with cardiologists, primary care providers, dietitians, pharmacists, physical therapists. That interprofessional collaboration is key to optimizing outcomes.
Definitely. And beyond the modifiable factors, we have genetics, aging itself. The source even mentions psychological factors like stress and anger impacting the heart. It's a truly holistic challenge.
It is. Which brings us back to population health. That healthy soldier effect data you mentioned earlier is quite thought-provoking. The idea that veterans initially screened for fitness might actually face higher cardiovascular mortality later on compared to non-veterans.
Yeah, it flips the initial assumption, suggesting maybe service itself or factors post-service increase long-term risk in ways we haven't fully accounted for.
Exactly. So the provocative thought for you, our listeners, is this. If established epidemiological assumptions about risk in large groups like veterans can be challenged by new data showing potentially higher long-term risk, how should that change our approach? How do we refine our screening tools, our prevention messages, and our long-term follow-up strategies to ensure we're truly meeting the needs of specific populations, considering the full arc of their life experiences and potential exposures, not just their initial health status?
A crucial question indeed. How do we ensure our assessments are sensitive enough to the unique, long-term trajectories of different groups? Something important to consider as we strive for equitable and effective cardiovascular care.
Absolutely. That ongoing questioning and refinement is what drives better care. We hope this deep dive has given you valuable tools for your own practice and understanding.